Hello, and thank you for joining us for this event, When Stroke Happens, What to Do. May is National Stroke Awareness Month. In both the US and globally, stroke is a leading cause of death and disability. Yearly, 15 million people suffer from stroke worldwide, with another 5 million dying from stroke and another 5 million becoming permanently disabled. So basically, stroke is a really big deal in the healthcare world, hence our discussion today. So first, let me start with some introductions. My name is Jessica White. I am a fourth-year medical student on the cusp of graduating this May. I'll then be traveling to Minnesota to complete a neurology residency program at the Mayo Clinic. I'd also like to introduce Dr. Michael Guido. He is a vascular neurologist at Stony Brook University Hospital. He's also the director of the Stony Brook Neurology Stroke Program and the co-director of the Stony Brook Cerebrovascular and Comprehensive Stroke Center. I'd also like to introduce Dr. David Fiorella. He is a neurointerventionalist at Stony Brook University Hospital. He is the Neurointerventional Radiologist Director and also co-director of the Stony Brook Cerebrovascular and Comprehensive Stroke Center. So now let's get started. I'd like to just remind everyone that you can put your questions in the comments section and we will do our best to answer them. So I'd first like to start asking Dr. Guido, what is a stroke?
Good morning. And welcome everyone to our live stream. Stroke, at its most basic, a stroke refers to any abnormality of blood flow to the brain, which then leads to dysfunction and cell death of the brain tissue. It can be categorized into two different main topics. The most commonly thought of thing in stroke is an ischemic stroke. That's where an artery becomes blocked and a part of the brain does not get enough blood to survive. That part of the brain then dies, leading to neurologic dysfunction. The second type is what we call a cerebral hemorrhage, and this is where, for some reason, a blood vessel bursts, leading blood to leak into the tissue of the brain itself, also causing the brain cells to die and malfunction.
Great. So kind of on that topic, what are the symptoms of stroke? What should people be looking for?
The symptoms of stroke are quite varied. It's kind of like real estate. It's all about location. So the exact symptoms depend on where the stroke happens. So common things that you can see would be weakness on one side of the body. That's if the stroke is happening in the motor area. You can also get numbness or loss of sensation on one half of the body if it's from the sensory area. You could get loss of vision either in one eye or in one half of both eyes, again, depending where it is. Facial weakness is something that's commonly recognized. Difficulty speaking, which could either be slurred speech, as if you're sounding like you're drunk, or it could be an inability to speak, such that you either talk nonsense or can't say anything at all, or are unable to understand what other people are saying to you. There are others. Dizziness and room spinning is a less common symptom, but it can happen. Usually in that case, it'll be associated with one of the other symptoms I mentioned. But if it happens suddenly, that's also another thing to consider. Loss of consciousness is less common, but still possible.
Wow, so there's a lot of things that could kind of give you an idea that maybe a stroke is happening. Kind of that being said, what kind of strokes are most common?
Well, by far the most common is the ischemic stroke. Ruptured blood vessels are relatively rare. About 80% of all strokes are coming from a lack of blood flow. Most commonly, that's due to hardening of the arteries within the brain itself, although not uncommonly, it could be coming from a blood clot that began someplace else, most typically the heart, and then traveled to the brain.
Okay, so you mentioned kind of hardening of the arteries. So that's kind of what you think of a lot of times with people having heart attacks, which are typically in older people. So, are strokes mostly in older people? Is that something that you worry about in the elderly, or can young people have strokes too?
Certainly, in most things in life, the older you are, the higher the risk. So there's no question that strokes primarily occur in the elderly. However, they can definitely happen in younger people. We even see strokes in children. Now, if you're talking about a younger person or a child, then the causes tend to be somewhat different. Now, it's not so much hardening of the arteries. Then you're thinking more about injury to the arteries or a clot from the heart or some abnormality in the way your blood clots, some disease that you inherited and didn't know. So the causes are different, but the symptoms are the same, and it's just as urgent, and if anything, more urgent, because they tend to be more devastating when occurring in younger people.
Great. Now, you mentioned that there were these two different types of strokes. So the ones that are ischemic, where, a blood clot or, travels to an artery and kind of blocks it. But there's also this hemorrhagic stroke where you kind of bleed into the brain. Dr. Fiorella, maybe you could kind of discuss, types of brain bleeds that can happen in young people and how that could be considered a stroke in a younger person.
Sure. So the two most common types of bleeding stroke that occur are strokes related to either high blood pressure or disorder of the blood vessels in the brain, where the patient spontaneously bleed into the actual brain tissue itself. So that's called an intracerebral hemorrhage or intraparenchymal hemorrhage. Another category of hemorrhagic stroke is a subarachnoid hemorrhage, which sometimes can be caused by trauma. So a head bonk or a car accident or something like that can cause some bleeding into the fluid space around the outside of the brain. Alternatively, if it happens spontaneously without trauma, the most common cause is a ruptured brain aneurysm. And both of these types of hemorrhagic stroke we treat fairly regularly here at Stony Brook.
Great. And just for the viewers who are listening, what is an aneurysm? How would you describe that?
So a brain aneurysm is basically a bubble that forms off the wall of one of the arterial blood vessels that supplies flow to the brain. So the way I describe it to patients most commonly is if you've ever seen a garden hose, when the garden hose forms a little split in the side of it and sort of the clear part starts bulging out, the hose still functions normally, but that clear portion is not covered by all the normal protective linings of the hose. And so as you use that hose over and over again, and fluid flows through it, that clear part of the bubble, which is weak-walled, starts to become bigger and bigger and bigger and can eventually burst. And so we see brain aneurysms that are like this. When you look at them surgically, that's exactly what they look like. Just a portion of the blood vessel wall where there's a outpouching, a bulge there, and it's not covered by all the normal linings of the blood vessel, so it's a weak spot. The natural history of these is they tend to enlarge over time and then ultimately rupture, causing bleeding into the fluid space around the outside of the brain. So these are occurring on arteries. So when there is a bursting of one of these brain aneurysms, it's arterial force bleeding that is occurring into the fluid space around the outside of the brain, which as you can imagine is a pretty dramatic thing to have happen to you. You hear people all the time, so-and-so had a ruptured brain aneurysm and fell over and didn't survive it. So anywhere between 15 and 50% of people do not survive the rupturing of a brain aneurysm. Once you do survive, come here to Stony Brook and we're able to go in and repair that portion of the artery that is ruptured or bled.
That's great. Now, you kind of mentioned that, these bleeds happen really fast. So are there any symptoms that people could experience prior to that? Because it's, an arterial supply. So maybe they might have some kind of like headache a couple of days before, or any other kind of symptoms they might experience?
Yeah, so we see brain aneurysms in two different categories, unruptured and ruptured brain aneurysms. Unruptured brain aneurysms are typically found incidentally, so somebody gets a scan for dizziness or headache or something, and you find an aneurysm before it's ruptured. And a lot of times it's really a fortunate thing that we're able to find these because imaging is so prevalent now in patients prior to the aneurysm actually rupturing. So most frequently, brain aneurysms are asymptomatic up until the time of rupture. Occasionally, if a brain aneurysm gets very large and is in an anatomical position where it can cause symptoms, it will push on a portion of the brain or one of the cranial nerves and can cause symptoms related to local mass effect or pressure. This is less common, though. Most brain aneurysms, when they're unruptured, are completely asymptomatic. When they do rupture, as you inferred, it's a very dramatic thing that happens. And so a ruptured brain aneurysm typically presents, the classic presentation, a sudden onset of severe headache, worst headache of life, different from any of the normal headaches that you would experience. Patients oftentimes say something like a cannon went off in their head, felt a sudden onset of just the worst headache that they've ever had. As the pressure inside of the brain starts to increase from the bleeding, patients will oftentimes rapidly lose consciousness. So the pressure in the brain starts to increase when there's bleeding around the outside of the brain from an artery, because of course the brain is in an enclosed space, the skull, there's no room for it to expand, and so the pressure inside of the head gets quite high quite quickly. That limits the amount of normal blood flow that can get to the brain, and then that's what causes unconsciousness sometimes in these patients. And so having a ruptured brain aneurysm is a true emergency, and so sudden onset of severe headache followed by unconsciousness is something that if you witness that, that's important to indicate to the EMS that this is an important history, because if they know about this, they know to take the patient to the closest comprehensive stroke center, which in Suffolk County is typically Stony Brook.
Great, because they could come here and get some really great treatment options and hopefully, have a good outcome. Kind of to move on a little bit, I'd like to kind of point this back to Dr. Guido and then Dr. Fiorella, maybe you can kind of tag along afterwards. Just a generic question, how do you treat stroke?
Okay. So the most important thing to think about when treating stroke is that time is of the essence. Brain cells do not really have any reserve of oxygen or glucose, and so they'll start to die immediately when there's a lack of blood flow. The only real way to treat a stroke is to restore the blood flow as quickly as possible. The medical way to do that is with a medication, medications called either alteplase or tenecteplase, two very similar medications that are designed to break down clots. When you do have a blood clot in the body does have ways to try to remove the clot and restore blood flow. There's a chemical called TPA, or tissue plasminogen activator. And what that does is it activates a cascade of compounds that helps dissolve blood clots. So what we've done is we've invented some modified versions of the natural compound, which we could then infuse into patients with the hopes of helping the body break down those clots. Those medications need to be given within 3 to 4.5 hours of the onset of the stroke. Once you're past that, then there is really no medical treatment that we can do to reverse the stroke. And at that point, we focus on rehabilitation and prevention.
Great. And Dr. Fiorella, do you want to maybe discuss some of the surgical options that are available to stroke patients for treatment?
Sure. So for the intravenous TPA that Dr. Guido is referring to, that's very effective for small strokes involving the smaller arteries of the brain. When the larger arteries of the brain are occluded, the intravenous TPA becomes a little bit less effective. So if the large blood vessels of the brain are occluded, those are cases where I take those patients into the cath lab. We work up through the inside of the blood vessels to grab onto the clot and pull it out of the brain, or aspirate the clot out of the brain with a suction catheter. So we remove the clot from the blocked blood vessel and restore flow that way for the larger vessel occlusions. And so oftentimes Dr. Guido and I work as a team. He'll give the intravenous TPA to the patient in the emergency room. Then they'll be brought immediately to the cath lab for me to go up with the catheters and remove any clot that the IV TPA is not dissolved up. So a lot of times we work in concert with both types of interventional therapies to improve blood flow to the brain.
Great. And Dr. Guido mentioned that there is a time frame that they can apply TPA. Is there a certain window of time when the patient has to be there at the hospital to get this mechanical thrombectomy, this procedure done?
So for mechanical thrombectomy, the time cutoffs are much more liberal than they are for intravenous TPA. Intravenous TPA is approved up to 3 hours, but can be given up to 4.5 hours after the onset of stroke symptoms. Interventional therapies through the artery, so thrombectomy procedures like what I do in the cath lab, those don't have a stringent time frame. So we have physiological imaging that we can perform for patients who present late in the window to assess as to whether they have brain left to save. Based on that physiological imaging, we can take patients oftentimes up to 24 hours, sometimes beyond 24 hours, if there's a considerable mismatch, meaning that there is a small area of brain that's irreversibly injured, but a large area of brain that still remains at risk. Those are actually great patients for intervention. So there are really no traditional time cutoffs for interventional therapy for stroke, at least within the first, say, 24 to 36 hours after presentation. So we have a much longer time for the interventional therapies than we do for the intravenous medical management therapies.
That's really great. So that's kind of a hint for everyone out there that, if you think somebody's had a stroke, but it's been more than 3, 4, 5 hours, still take them to the hospital, because there's still potentially something that can be done to actually remove the clot. And even if they can't get the clot removed, it's still good to kind of take them to the hospital and have them worked up so that maybe this won't happen again in the future. So kind of in that vein, if you think someone's having a stroke or someone around you is having a stroke, is it best for you to drive them straight to the hospital, or should they call 911? Dr. Guido, what do you think?
Unless you're literally across the street, call an ambulance. The start of care begins even within the ambulance itself. You may need to be stabilized. They also may want to assess you and decide where the most appropriate location is. And in addition, under certain circumstances, you might have the mobile stroke unit dispatched to you as well. So it's always better to call an ambulance. It's also a good idea not to attempt any treatment on your own. You may have seen that for heart attack, they recommend if you think you're having a heart attack, take an aspirin right away. Because there's no way to know whether you're having an ischemic stroke or a hemorrhage, you should never treat yourself. Just call the ambulance and let us do all the work.
That's great. And you kind of alluded to the mobile stroke unit. So I think that might be a great time for us to, segue into that a little bit. How does one get the mobile stroke unit to come to their house? Do they call 911 or is there a separate number they have to call?
This is all done through the standard EMS. So you call 911, and if it's appropriate and the unit is in operation and near enough by, it will be dispatched directly from emergency medical services. You can't directly call the mobile stroke unit. So again, you call 911 and professionals will take care of everything that needs to be taken care of.
Okay, great. And I just noticed from the chat, we had a question from Michelle who's asking, what type of screening is there for strokes?
It depends on what exactly you're talking about. Primarily, you're screening someone for stroke, it's your basic risk factors: blood pressure, cholesterol, sugar, carotid arteries, sleep apnea. It's really your general medical care. And the risk factors for stroke in general are pretty much the same as they are for coronary disease. So it's nothing overly special. It's all the things that you would be getting at your normal annual checkups. Oh, and of course, I forgot to mention, obviously, stop smoking.
Yes, stop smoking and, treat the underlying conditions like diabetes and hypertension are always good things. So go see your primary care physicians for sure.
Exactly.
We've seen kind of the mobile stroke unit on the roads, and I think I'd like to talk a little bit more about that because I think that's something really great and innovative that Stony Brook is doing. So, Dr. Fiorella, could you kind of describe what exactly is that ambulance? What is a mobile stroke unit?
So the mobile stroke unit is basically almost like a mobile stroke emergency department that is able to travel around like an ambulance and respond to calls with the local EMS service, where there's the idea that the patient may in fact be having ischemic or hemorrhagic stroke. So the ambulance is specially equipped with a number of different things. One of the things that it has is teleneurology. So our on-call stroke neurologist, Dr. Guido, for instance, can actually observe the patients in the mobile stroke unit and do a quick examination and determine whether this patient clinically actually looks like they're having a stroke or whether this is likely some other type of pathology. If the patient does look like they're having a stroke, there's actually a CAT scanner in the unit. And why that's important is because of something Dr. Guido talked about before. Oftentimes from the presentation, it's impossible to tell if the patient's having an ischemic stroke, meaning that there's a blocked blood vessel in the brain causing the symptoms, or whether the patient's having a hemorrhagic stroke, meaning one of the blood vessels in the brain is ruptured and the patient's having bleeding into the brain, which is causing their deficit. The problem with not being able to differentiate these two things clinically, because clinically they can look exactly the same, is that the treatments are exactly the opposite. So if you're having bleeding inside of the brain, we want to lower your blood pressure and thicken up your blood. If you have a blocked blood vessel going to the brain, we want to increase your blood pressure to improve perfusion of the brain and give you medications to thin out your blood or bust up the clot, like the TPA medication, to restore blood flow to the brain. So having that CAT scan in the ambulance allows us to make this determination, this diagnosis, not at the door of our ER, but right at the door of wherever the patient is. So at the patient's in the patient's driveway, at their place of work, wherever they presented with their stroke. So the ability to obtain an accurate diagnosis and initiate treatment early is remarkably earlier with the mobile stroke unit than it is with a typical situation where an ambulance picks up a patient, has to bring them to the hospital, and then they're assessed at the hospital. So they get a full clinical exam by one of the stroke neurologists. They get a CAT scan that determines whether it's a hemorrhagic or ischemic stroke. If it looks like an ischemic stroke and the patient has a severe stroke symptoms, we can also inject intravenous contrast and do a CT angiogram. And what that tells us is if there's a large vessel occlusion, meaning the kind of stroke that needs the interventional therapies that we offer at Stony Brook. If we see a patient in the mobile stroke unit with a large vessel occlusion, we get that information. I get it on my iPhone. We can also get it directly from our PACS. So that means I can alert the team in the hospital that we have a large vessel occlusion coming in. We can meet that patient right at the door of the hospital, take them right into the cath lab for revascularization. So the mobile stroke unit has markedly reduced the amount of time it takes for us to identify that a patient's having a stroke, to get them to the appropriate hospital the first time and to initiate these life-saving therapies early. And as Dr. Guido mentioned, time is brain in acute stroke. And so the mobile stroke unit has massively decreased the amount of time it requires for us to diagnose stroke appropriately and to give the appropriate medications immediately and to get the patient to the right hospital the first time. And so this program has resulted, again, in a marked improvement in our ability to deliver these therapies early. And we've already, after having the program running for 2 years, seen a significant reduction in both disability and death for patients presenting with stroke who come to the mobile stroke unit versus who come to us through other means of transportation or transfers from other hospitals.
That's great. So basically what I'm understanding is the mobile stroke unit shows up and they can, put you in an imaging in the CAT scanner and determine if you need blood pressure medication or if you need this TPA to kind of break up a clot. And then also if you potentially need to have a surgical procedure done, in which case they can take you right to a comprehensive stroke center like Stony Brook University Hospital and get you the treatment you need as fast as possible. So that sounds really awesome. Kind of on that note, so it launched in April of 2019, I believe. So Dr. Fiorella, how many patients has the MSU program helped since then?
There's been something in the order of over 2,000 calls that the MSUs have been on. I think we've transported 700 of those patients. So, and it's not uncommon in these cases that we see the patients and they're not having an acute stroke. They don't look like an acute stroke, in which case the patients are just turned back over to the local ambulance service for transport to the nearest hospital that can provide them with the care that they need. Of the 700 patients that have been transferred, I think in the neighborhood of 70 or 80 have gotten intravenous TPA, and an equal amount have been identified with large vessel occlusions who have come directly to Stony Brook. And so, it's hundreds of patients in just this first 2 years have been helped by the mobile stroke unit in terms of getting them a rapid diagnosis and rapid treatment for their stroke.
Great. And how do you know if the mobile stroke unit is available to you? I know you mentioned you just call 911 and they could potentially show up at your door. So
yeah, so the mobile stroke units cover two areas. They're at exit 58 and 67, I believe, on the LIE, and they cover a radius around them. So much of Suffolk County has access to mobile stroke unit services. So when there's a call that comes into EMS, if that call has any indication that it is an acute ischemic stroke or a hemorrhagic stroke, then our units, if they're available between 8 a.m. and 8 p.m., will co-respond with the local units to that call. And then the assessment will be made if this is a patient that is best served by the mobile stroke unit or best served by their local ambulance crew.
Wow, that's really exciting stuff. The mobile stroke unit program sounds really great. Kind of to pivot a little bit, I'd like to go back to Dr. Guido and just ask some questions. If you're having a stroke, are you disabled forever?
Not necessarily. The majority of strokes are actually relatively small, and patients do recover over time. The thing is, when a stroke happens, the symptoms start immediately. You will get better, but the recovery from a stroke, particularly if it's untreated, generally takes anywhere from 6 to 18 months or even longer. So patients do get better. Everyone gets better than they were when they first arrived. Some patients get better, get completely back to normal. Many patients get back to full functionality, even though they're left with some symptoms. However, what it does take from the patient is a fairly long period of rehabilitation. And the harder you work in your rehabilitation, the better you'll get long term.
Great. And actually, Tracy had a question. Is a TIA considered a stroke? And if not, is it as dangerous as having a stroke?
Technically, a TIA isn't a stroke because there was no damage to the brain. However, you really should approach a TIA as a stroke that got better very quickly, because for all intents and purposes, it's the same thing. It still shows that you have something wrong with you that predisposes you to having an event. And the risk of having a stroke in the first 24 hours and then even in the first month after a TIA is much higher than in baseline. A TIA should still be considered an emergency situation. Now, if your symptoms are resolved, where you don't need any of the specific treatments that we had mentioned earlier in this discussion, but what you need is a rapid assessment to find out what your risk factors are and have those risk factors dealt with as soon as humanly possible. So it is still best to go to an emergency room if you're having it the same day. Rapid outpatient workup is available, and Stony Brook will soon be starting a rapid assessment clinic in our Colmac office for patients who've had TIAs who did not go to the emergency room. Nevertheless, if you're had one that day, it is safer to go to the emergency room.
Great. So what I'm hearing is if you have any symptoms of a stroke, even if they start to resolve, you should go seek care at the emergency room just to be safe and to make sure that nothing else is going to happen, or to potentially prevent anything happening in the future, although you can't always 100% prevent it. So seek care if you're having stroke symptoms. So kind of to go on that vein, we actually had a question from Kim. We mentioned the stroke symptoms, but are there any signs you would see in a patient who might be having a stroke?
It is the same symptoms I mentioned before. There really aren't any warning symptoms, because as soon as you have a symptom, that means you're having a stroke. So again, any weakness of the face, weakness of the body, change in speech, dizziness, loss of ability to walk, loss of ability to see, slurred speech, anything like that, the first sign is your symptom actually happening. They're other than hemorrhages, they're rarely preceded by headache. In fact, rarely even associated with headache. And the first time you see a symptom, that's when you're having your stroke.
And go to the emergency room. Okay. Are strokes genetic? Is that something, if you have a family member who's had a stroke, should you be concerned?
In most cases, they're not genetic per se. There are a few extremely rare genetic disorders that lead to stroke, but they do tend to run in families. And generally, it's because the risk factors tend to run in families. So it's not so much the stroke itself, it's the family history of high cholesterol or high blood pressure or diabetes that is what's putting you at risk. And that's what runs in the family. It's usually the risk factors. So even if you're a family member, if you don't have a family member who had a stroke, but you have family members who've had heart attacks and diabetes, then you may still be at risk. And the best thing to do for that is to closely monitor yourself for the development of any of those risk factors. Again, generally in conjunction with your primary care doctor.
And don't smoke or quit smoking if
Exactly.
you are smoking. Okay, great. Why do some people who have a stroke do okay and others do not?
It is all about location and size. So while you may have heard that people only use 10% of the brain, that's not really true. Every part of the brain is important. However, some areas are more important than others. There are large areas of the brain where a small stroke would affect you in such a minimal way you wouldn't even notice. Whereas other areas, if you're hitting the primary motor cortex, which controls all of your ability to move, even a small stroke there could be devastating. It really has very little to do with why the stroke happened or what your risk factors were. It's really almost about luck. So it's hard to predict who would have a devastating stroke versus who would have a minor stroke.
Gotcha. So when it comes to the brain, there's some prime real estate and there's some other real estate that maybe isn't so prime. So if you hit some of those prime centers, like your motor cortex, which controls your movement, or the parts of your brain that control speech, it can be a little more difficult. Okay, we actually had a question from Judy too. Do you feel like the incidence of stroke is getting less due to awareness?
I don't think the incidence is dropping all that much, certainly not as much as we would like. The mortality and morbidity is definitely decreasing faster. So what stroke awareness has done is getting more people to the hospital so we can adequately treat them more quickly and potentially save more of their brain. Incidence has dropped a bit, but the good news is the mortality has dropped far greater than the incidence has dropped.
Great. And that's probably due to programs like the Mobile Stroke Unit program or having comprehensive stroke centers like Stony Brook at patients' availability. So that's great. I'd like to actually switch to Dr. Fiorella. So I just mentioned the Comprehensive Stroke Center. Stony Brook is one. So what makes a comprehensive stroke center different?
So Comprehensive Stroke Center is equipped with all of the staff, personnel, and facilities to deal with both hemorrhagic and ischemic stroke 24 hours a day, 7 days a week. And so Stony Brook has had a system to offer thrombectomy services and all spectrum of services for hemorrhagic disease in this manner, now going on 15 years. So we're the longest standing full service comprehensive stroke center in Suffolk County. And we've had that for a long period of time.
Great. And is Stony Brook involved in any clinical trials for stroke?
Yeah, one of the nice things about Stony Brook is almost all the major clinical trials that have run for both hemorrhagic and ischemic stroke we've participated in, oftentimes as in a national or international leadership role. So almost all of the new devices that are available for both hemorrhagic and ischemic stroke we have access to here before anybody else does in the rest of the country or the rest of the world in some cases. And so we've been very fortunate to be a high volume academic center with a track record of excellence over a long period of time. As such, when companies are developing new devices or new technologies come available, a lot of times they seek us out to participate in their trials to seek a regulatory approval. So many of the devices that we use every day in stroke, we've had access to and experience with here even years before they were approved by the FDA. And so I think the level of experience and expertise that you can get at a place like Stony Brook just far surpasses what you would get really any place else in this area for sure.
Great. So Dr. Guido, you've kind of mentioned this before. How can you prevent having a stroke?
The mainstay of prevention is to control your risk factors. Don't smoke, don't use illegal drugs, control your blood pressure, control your sugar, diet, exercise. If you have sleep apnea, treat it. That's the primary way of certainly preventing the first stroke. If you've had a stroke, then all those things still apply, but then you will require medication, usually something like aspirin, to reduce the risk of having a second stroke.
Great. And in kind of the vein of, prevention, but also awareness. And, you've mentioned some of these symptoms. One of those was, beds, like kind of spinning, that kind of thing. Scott actually had a question about vertigo that, he's had vertigo his whole life, but he's had some really severe bed spinning episodes recently. So could he be having a stroke in addition to the, vertigo he's normally experiencing?
Vertigo is very tricky. Unlike most other stroke symptoms, this is very common. Mm-hmm. And in most cases, it's benign. It's usually a problem coming from your inner ear. So strokes presenting as vertigo are relatively rare. And if you've had something your entire life, then the odds of it being a stroke are much less, because strokes are usually dramatic one-time events. It's not the kind of thing that keeps happening off and on for a very long period of time. Mm-hmm. And if you're prone to vertigo, something could certainly trigger a more severe episode. Generally, when I talk to a patient who has a long-standing problem, my advice is if it feels like it's always felt, then it's not likely to be something new. If it feels different, and if you recognize, say, you know what, yes, I've had vertigo before, but this feels really different to me, then you should probably get evaluated. Chances are it's still nothing, but it's better safe than sorry. So you're better off having it assessed.
Gotcha. That's some great advice. And Dr. Fiorella, what would you say is the most important thing to remember about stroke?
The most important thing is just, as again, Dr. Guido's talked about, the time is brain, and getting to the hospital immediately is of critical importance, and getting to the right hospital the first time is of critical importance as well. And so if you're having an acute ischemic stroke, especially if it's a severe stroke that's obvious that it's a stroke, so complete paralysis on one side of the body, inability to speak, almost always that's going to be either a large vessel occlusion that requires a trip to the cath lab or a hemorrhage into the brain if you're having something that's obvious to everybody around you that it's a stroke. Those patients really need to get to a comprehensive stroke center as soon as possible. For patients who have, say, unruptured aneurysms or elective cerebrovascular issues, they have much more time than somebody who's presenting with an acute ischemic stroke. And what I'd say for patients like that is it's really important to sort of investigate the institution that you're going to, the level of experience at that institution in treating the disorders that you have, and really get to know your physician there and how frequently they perform the procedures and the interventions that you require for your problem. And so we sort of see patients in these two different categories of presentation, like the most acute presentation you could possibly have, where every second matters, an acute ischemic stroke. And then patients sometimes we see electively who come in who have, say, an unruptured aneurysm for treatment that can be done on a more elective basis. But for an acute stroke, really the most important thing is time is brain, and you need to get to the right hospital as quickly as you can for your treatment.
Great, thank you. And I saw we had a question from Anne. Just so everyone knows, this video will be available after. It'll be archived on Facebook and YouTube after the live broadcast. So for anybody that wasn't able to tune in right now, you can feel free to share this video via the Facebook and YouTube pages. Marie also had a question. She said she came on a little late, but she wasn't sure if stroke showers were discussed. So I don't know, Dr. Guido, Dr. Fiorella, if any of you have anything to say about stroke showers?
I mean, that isn't strictly speaking a term. I think what she's referring to is someone having multiple strokes at the same time. That would generally occur either from clots coming from the heart, or in someone who's young and healthy as she was, it would be due to some kind of disorder affecting your blood vessels or your blood's ability to form clots, usually making it clot more often than would be normal. And that's why stroke in young people, they do tend to be bigger, somewhat more devastating, and of very unusual causes. But an older person can have a shower of strokes too. That usually would then come from a cardiac source. As long as you seek treatment as soon as the first symptom starts, it doesn't necessarily affect emergency management. Certainly the long-term management is, as always, dependent on whatever we find to have been your cause once you have the complete workup in the hospital.
Great. And that's probably why, as you had mentioned earlier, if you have something like a TIA, so a transient ischemic attack, it's important to still seek treatment, because you could potentially have a second stroke for the same reason you had the first stroke, or the TIA. So great. I have some more questions that are a little bit more nuanced, so I'm going to switch us over to Dr. Fiorella. You kind of mentioned, the mechanical thrombectomy, using a catheter to kind of go through the vessels to kind of retrieve a clot. So how is the catheter steered through the blood vessels during endovascular procedures to reach a clot or an aneurysm?
Yeah, so we've just had a remarkable evolution of devices that we have available to us, to where our procedures have become much safer, faster, and more minimally invasive over time. And so frequently through a small puncture site in either the femoral artery, which is down by the leg, or in the radial artery now more frequently, which is up in your wrist, we can move our catheters through the inside of the blood vessels under X-ray guidance using little guide wires that steer them exactly where they need to go. So over just the past 20 years that I've been doing this, the catheter technology and microwire technology and device technology has just evolved so quickly that what I tell people when they're thinking about this field is that it's really a wonderful field to practice in, because it seems that every 6 months we get a new technology that allows us to do something safer, easier, faster, or sometimes allows us to do something that we never would have imagined would have ever been possibly done through a minimally invasive catheter-based procedure. So more and more, we're having new technologies that are allowing us to do things that in the past would never have been possible. And so our procedures is just becoming safer and faster and better for patients, with better results for patients. And they've done the field has just progressed so remarkably just over the past 20 years that I've been involved with it. And like I said, on a month-over-month basis, things just keep getting better and better. And that's why coming to a place like Stony Brook is so important, because we participate in all of these ongoing innovations and trials. And so again, all the newest and latest devices are available here. So while for acute ischemic stroke and acute presentation, time is brain, getting to the nearest best place is really important. For elective procedures, again, where you have time, it's really important to carefully consider the hospital that you go to for your procedure. So say in Suffolk County, our hospital is ranked number 41 in the entire United States for neurosurgery and neurology treatments. And so again, if you're in Suffolk County and you're staying in Suffolk County for treatment, there's not even another hospital in the county that could even be considered for U.S. News and World Reports in the neurosurgery and neurology arena. And so to go someplace else really wouldn't make a lot of sense for an elective brain procedure. And so if you're having anything elective done, what I'd say the most important thing to remember is you only have one brain, and you should bring that to the place that can treat you the absolute best. And I have every confidence in the world that our program, particularly in this county, is by far the best, most experienced place that you can come to have the best outcome for whatever it is that you have in the cerebrovascular or neurology arena.
Great. So you kind of mentioned these elective procedures. So something like that would potentially be, let's say they discovered this aneurysm, like you had mentioned before, this ballooning of an artery in the brain. So let's say a patient, incidentally discovers they have one of these and decides to come to Stony Brook for treatment. How do you decide whether to stent, clip, or coil their aneurysm?
Yeah, so the vast majority of brain aneurysms these days can be treated through a minimally invasive procedure. So almost everything can be done now via an endovascular type of treatment. And so, again, if you have a brain aneurysm and somebody suggested that it has to be treated with open brain surgery, again, it's really important to seek a second opinion. And Stony Brook is a good place to come for that because, again, because we have access to all the new devices and technologies, many brain aneurysms that in the past or even in the present at a lot of places that would be treated with surgical clipping, we're able to treat very easily through a minimally invasive procedure here in the hospital that often just requires an overnight stay. So a lot of times where people would have in the past required big open brain surgeries with long recovery times associated with getting their elective brain aneurysm treated, we're able to provide definitive curative treatment through a fast, easy, and minimally invasive endovascular procedure and basically get the patients out of the hospital the next day. It's not uncommon that we see patients with like a complex brain aneurysm. They're treated on a Friday and they're back to work on a Monday with really minimal disruption of their life and their lifestyle. And that's really what the Cerebrovascular program here is after, being able to treat patients with complex diseases without causing really any disruption in your normal life or the normal things that you do and getting you immediately back into your normal life.
Great. So these endovascular procedures sound really, really great. In that note, kind of when a patient's having a stroke, you've kind of hinted at this before, and I think you've mentioned it, but just to kind of reiterate, let's say I come in and I'm having a stroke. What determines whether I get TPA, so that, medication through my veins to kind of dissolve the clot versus you going in and actually retrieving the clot and pulling it out?
So the availability to get intravenous TPA is based on a couple of things. The most importantly is the time that you present. So for patients who come to the hospital within 4.5 hours, if they don't have a contraindication to intravenous TPA, meaning they're on powerful blood thinners like Coumadin, or they've had recent surgery, or they have another contraindication to TPA, most of those patients who present early do get intravenous TPA. But if you have a large vessel occlusion, meaning there's a blockage of a blood vessel that's large enough for us to see on the CAT scan angiogram, so your internal carotid artery is blocked or your middle cerebral artery is blocked, so a large blood vessel in the brain is blocked, then regardless of whether you were a TPA candidate or not, we'll typically take you off to the cath lab to revascularize that blood vessel, because while intravenous TPA is very effective for revascularizing the smaller strokes of the smaller arteries that are below the level of resolution of the CTA, for the larger blocked arteries, we know from multiple randomized controlled trials, some of which we participated in here at Stony Brook, that performing the interventional thrombectomy procedure is markedly beneficial in comparison to the intravenous TPA. So intra-arterial thrombectomy, removing the clot from the brain, is absolutely essential in large vessel occlusion. So if there's a big blood vessel blocked, you need to come to a place like Stony Brook where they can get that blood vessel open with interventional therapies.
Okay, great. So you kind of mentioned these patients with the large vessels. So you would think that's probably somebody with a really severe stroke. So if somebody comes to the hospital with this really severe stroke, they probably lost consciousness. I mean, maybe before that they were having trouble speaking or loss of the ability to move on one side, or, some of the symptoms that we've mentioned, but multiple symptoms. Is there a possibility that they could ever recover completely if they come with such a bad, severe stroke? I don't know if Dr. Fiorella, if you want to kind of take that question.
Yeah, I mean, that's one of the remarkable things about being able to operate at this time in this field, and that, we do quite a few thrombectomies a year. I think we're over 200 thrombectomies that we'll perform this year. And it's really, you have the ability to do basically a miracle for these people. And it happens oftentimes several times a week, where somebody's got an occluded blood vessel, they're totally paralyzed on one side, they can't speak or understand speech. Oftentimes they're having diminished level of consciousness. And you can go and remove that clot, and literally within a couple of minutes in the recovery room, they start returning back to normal. And oftentimes within the course of an hour or two, they can come completely back to normal. Our ability to get the blood vessels open with the new devices that we have at Stony Brook, at least, are in the high 90% range. So between 95 and 100% of the time, we can restore normal flow or near normal flow in these patients. So our procedures are highly, highly successful. So it's not a matter of whether we can get the blood vessel open. Really, our primary challenge is getting patients to the hospital early enough so that when we open the blood vessel, they can make a full and complete recovery. And so that's why we have all of this community outreach to educate people about stroke, and also why we have the mobile stroke unit to try to get patients to the hospital as early as possible for these critical interventional therapies. And so again, if you have a stroke and there's any way that you can get to Stony Brook, that's really going to be your best chance, if you can get there as quickly as possible, to have revascularization, restore blood flow to the brain. That's going to be your best chance of making a full recovery. But we have a substantial percentage of our patients, particularly the ones who get here early, who can make a full recovery from stroke in a very short period of time if they get a successful thrombectomy procedure or they get intravenous TPA administered very early.
Wow, that sounds great. And definitely a reminder that time is brain. So if you're having stroke symptoms, get to a hospital, call 911, do that as soon as possible. Dr. Guido, I'd actually like to throw this question at you. We kind of talked about the symptoms of stroke. Does stroke always cause an inability to speak or difficulty speaking?
Not necessarily. It really depends on where the stroke is. So any one of the symptoms that I mentioned before could occur in any combination or in isolation, particularly with the smaller strokes that are occurring deeper in the brain in the microscopic vessels that unfortunately Dr. Fiorella could not access. Those tend to only cause one type of problem. So you might lose strength on one side of your body, but maintain speech and sensation. Or you might lose vision, but nothing else happens. So it really depends on where and how large the stroke is, but it doesn't always affect speech.
Awesome. Yeah, I personally, that's why I love the brain. I think it's so fascinating. Why I'm going into neurology is because you could have something as simple as not being able to add or subtract, and that means you're having a stroke. And that's not to say that everyone out there who's having difficulty in math class should go to the hospital for a stroke, but it certainly can present with some really interesting symptoms. Very cool. After the first signs of stroke, how much time does someone have before they lose motor control of their extremities? Dr. Guido?
There is no specific time frame. Essentially, every second counts. Billions of neurons are lost every minute, and you have no real way of predicting how long you could last before the cell death becomes permanent. If you took a brain cell in isolation, like in a petri dish, within 4 minutes after a stroke starts, the cells would be lost permanently. In real life, you'll generally have other arteries that aren't blocked that are partially supplying blood to the area that's in jeopardy. And if you're fortunate, that could keep the tissue, even though it's malfunctioning, could still keep it viable for a prolonged period of time. And as Dr. Fiorella mentioned earlier, sometimes that could be even up to 24 hours. But you have no way of knowing that. And some people, the deficit is permanent fairly quickly. So don't think of it, oh, well, I have 4 hours to get treatment, so I'll wait a while. No, as soon as symptoms start, you need to call 911 immediately. I say this at the risk of sounding like a broken record, but yes, you need to get help immediately. Don't think about, well, I have time. You don't know how much time you have, and there's no way you could possibly know.
And this is your brain, and you only get one of them,
Yes.
as Dr. Fiorella mentioned. So yes, very important. So let's say you've had a stroke. After you're having a stroke, what is the best way to prevent another stroke? Dr. Guido, I don't know if you want to take that one.
It depends. The best way is to get treatment as quickly as possible. Assess not just for your emergency care, but also we have to figure out why it happened. The situation is different in everyone. Again, there are the rare circumstances where it's due to some kind of genetic disorder or a disorder of your blood vessels or blood clotting, or whether it's the more routine risk factors of cholesterol and sugar. We need to find out what type of stroke you had, what caused it, and then aim to interrupt those root causes. And that's really the only way to reduce the risk of having a recurrent event.
Great. So, see help for the immediate stroke that's happening, but then also probably follow up with someone like yourself, Dr. Guido, a vascular neurologist, to make sure that, you have everything in place to try and prevent the next stroke from happening. Kind of in that same vein, what type of medications does someone have to take after having a stroke to prevent another stroke?
Depending on what was wrong, most commonly, the one thing we prescribe the most often is cholesterol medication. People have a tendency to know whether they have a problem with blood sugar or blood pressure. Cholesterol is utterly silent, even more so than the other things, and that really tends to creep up on people. So many people will come in with their stroke, will identify their cholesterol as being high, and they'll say that they never heard of that had never been diagnosed before. So that's a very common medication we give. There'll always be something, excluding hemorrhages, we're talking about ischemic strokes, there'll always be something to thin your blood. Most commonly, it's an antiplatelet agent. Platelets are the blood cells that are responsible for forming clots and sealing, in normal life, sealing cuts. But in a adverse situation, platelets can attach to cholesterol and form plaque in the arteries, thus leading to the, quote, hardening of the arteries. So something like aspirin or occasionally some stronger medication in that vein is necessary. However, if we determine that your stroke was due to a true blood clot, as in something from the heart, then you'll need a stronger a true blood thinner, something like Coumadin.
Sure. Okay, great. So you've kind of mentioned like some medications that people have to take after having a stroke, but you would think, if they have severe, motor deficits, they're unable to move an arm or a leg, or maybe difficulty speaking, does someone need to have a really severe stroke to qualify for something like physical therapy or occupational therapy? Or, could anyone who even has a minor stroke qualify for that?
You will qualify for therapy based on any deficit you have. Again, most strokes are not the devastating ones that you think about or see on TV. Most strokes are relatively modest and leave people with some degree of function. But any disability that you have remaining could be amenable to therapy. We have patients who have a little weakness on their right side. It only really affects their hand. They can function normally, but they have trouble writing. You can still get occupational therapy for that. Many patients are still able to walk, but their balance is off. So they'll get physical therapy to help with their balance. You may have slurred speech, mild enough that everyone can understand what you're saying, but it's still not the way your voice sounded before. We can still get you speech therapy for that. So really, therapy is available for any residual symptom.
Great. And, have you noticed a difference in stroke recovery from about 5 to 10 years ago at all?
Stroke recovery is definitely improved. To a large extent, that's due to improvements in the acute management. If we can minimize the size of the stroke, then you'll have less deficit in the long term. Even if you don't get a complete cure, the treatments such as with intravenous tissue plasminogen activator or intraarterial thrombectomy, even if they don't return you instantly to normal, it still reduces the amount of long-term damage and reduces the long-term disability. Beyond that, really, in most cases, the recovery comes down to the patient. The harder you work and the more amenable you are to doing your therapy, and not just going to the rehab facility, but also doing your exercises even after the formal period of therapy is over, then the better you'll get.
Great. And, I'm just going to give one last question to kind of wrap things up here. I guess I'll throw it to Dr. Guido, and then Dr. Fiorella, you can kind of chime in too. Where do you see the stroke program at, Stony Brook in the next 5 to 10 years?
We'll certainly further expanding our services, likely at some point expanding the range of the mobile stroke unit, adding more staff, and just continuing to do research, continuing outreach, and essentially continuing just to do what we're doing.
Great. And Dr. Fiorella, any thoughts?
Yeah, I completely agree with everything that Mike has said, in that we're just seeking to continually expand our mobile stroke unit program. We feel if we could offer mobile stroke unit services to all people in Suffolk County, that we could potentially have in this county the lowest rate of morbidity and mortality from both ischemic and hemorrhagic stroke of any place in the world. And I think our program is a unique one, and potentially could be a model for other places in the United States in terms of stroke therapy going forward. And then in terms of the program, again, just continuing to participate in all of the ongoing research trials to try to advance not only treatment of our care of patients locally, but also the field itself, and trying to make our treatments and therapies more advanced and better for patients going forward. So not just to contribute to the patients in our area, but overall to continue to make big contributions in the field of medicine in cerebrovascular disease and move our understanding of these processes further.
Great. Well, thank you so much to everyone joining us here today. As you've heard, while stroke can be pretty devastating, there are groundbreaking advances and treatment options now available at Stony Brook University Hospital. So I'd like to take a moment to thank Dr. Guido and Dr. Fiorella for taking the time to speak with us today. For more information, if you want to find out more, you can visit stonybrookmedicine.edu/stroke. Also, this whole discussion will be archived on our Facebook and YouTube pages. So thank you so much again, and I hope you guys all learned a little something about stroke today.